duty to introduce our distinguished speaker for today's lecture. Dr. Salve is a community professor and he is a well-known figure in the domain of household health implications. His expertise touches on non-communicable diseases, epidemiology and surveillance, air pollution and health effects, health mitigation measures related climate change studies, community mental health and health system research. He has worked with central government, state governments and international agencies as an expert member. He was also part of interministerial central team for assessing response for COVID-19 pandemic in the state of Maharashtra and Rajasthan. He is also member of WHO Collaborating Center and Minerva scheme at AIIMS. Dr. Salve is coordinator of Collaborative on Air Pollution and Health Effects Research in India, CAFR India, funded by Health Effect Institute, Boston, USA. He has an experience of conducting 30 funded community-based research projects. His work has been rewarded in several terms. He received Dr. Sushil Nair Young Leaders Oration Award and Presidential Award by IAPSM. He also received fellowship from Indian Public Health Association. Dr. Salve received an award for contribution as resource faculty in skill e-learning and telemedicine facility at AIIMS. He has more than 60 publications and a book chapter on mental health in IAPSM textbook of community medicine. Dr. Salve brings unique flavor to IASTA monthly online lecture series by bringing in the health aspects of aerosols. And I am sure that participants of this lecture will be greatly benefited by his expertise. Let us now hear Dr. Salve. Dr. Salve, thank you.
Yeah, thank you and good evening and namaskar to all the viewers. So at the outset, let me thank Indian Aerosol Science and Technology Association, particularly Dr. Rastogi for inviting me for this very important lecture series. And I see this as a very apt opportunity to interact with the cross expertise. So I belong to from the health science and you all belong to exposure science. So this is what my work has been so far. I'm also advocating this, the mixing and the more collaboration, talking and discussion with the inter-expertise to take this agenda of mitigating impact of air pollution on health forward. So let me share my screen. I hope my screen is visible.
Yes. Yes, it is visible.
Yeah, thank you for confirmation. So we'll be discussing the actions on mitigating health impact on air pollution and whatever the work we have done so far at AIIMS. So I will take cues from that work. So these are the learning objectives. What are the environmental risks, health impact of air pollution, evidence from India, why there is need to take action on air pollution effects, and major domains for action, challenges and way forward. I have actually structured this presentation by taking the audience as informed by Dr. Rastogi that they are mostly from the exposure science. So sort of, I believe that they have very I will say the very minimal exposure with respect to the health studies and health evidence. So I'm focusing this talk on that aspect from the health side. So when we talk about the community health, so there are 5 dimensions of the community health or holistic health, what we talk about in the public health discussions. So environmental is an important component to achieve a community health. So without environmental health, we will not able to achieve the community health or a holistic health at the community level. And why this is important per se in terms of the epidemiology. So almost 24% of the disease globally and the 23% of mortality are attributed to the environmental exposures. So majority contributed by the cerebrovascular diseases. You can see in the diagram here, starting from stroke, ischemic heart disease, unintentional injuries, cancer, and chronic respiratory diseases. So the burden is huge as far as the environmental risk exposures are concerned. Coming to the labeling environmental risk, so you can see the first and foremost is unsafe water, sanitation, and hand washing, which we all know. The last few decades after independence, we are struggling to address the issue of diarrhea, and now we are sort of, due to various initiatives, we are able to address the issue of acute diarrheal episodes leading to the neonatal and childhood mortality. The second one is the air pollution. You can see here particulate matter air pollution and ambient ozone pollution are the level 3 risk, and level 4 risk are the ambient particulate matter pollution and household level air pollution in the solid fuel. So here air pollution feature distinctly as far as the environmental risk are concerned. Hence, it has become very pertinent to study about air pollution, its risk, its burden, and its mitigation measures for all young scientists. As far as the impacts of the air pollution are concerned, so what we see and what numbers we usually quote is the tip of the iceberg. What most of the studies we do, we report the deaths in the global burden of disease study. We see the deaths are reported, the daily disability adjusted life years are reported, but much thing lies beneath the sort of iceberg here. So there are doctor visit, respiratory symptoms, and the lung function, decrease in the lung function, inflammation that is related to cardiac effects. So if you see the pyramid, the base is more larger, right? So that means the impact is more larger with the all the symptoms. So we really need to focus on these symptoms. We really need to focus on these symptoms when we advocate regarding the impact of the air pollution to the policymakers or to the community or to the scientists, so that they can take up this to generate more evidence. So this is very important to note. Coming to the health impact of air pollution, what are the evidences? So in this section, I just compiled the evidences which are published from India. I might have missed few, but I have tried to cover the major studies which are done so far. Coming to the all-cause mortality. When we say all-cause mortality, it is a mortality except the mortality or death caused by the trauma. So most of the studies, they assess the all-cause mortality. You can see here in one of the study where Balkrishnan et al. In Chennai, they have reported 0.44% increase per 10 microgram per meter cube in average PM10 concentration. Another author reported 137% increase due to PM10 in Delhi. And similarly with the ozone 0.307 and carbon monoxide 0.03. So all-cause mortality has been reported is positively associated with the increase in the pollution level recently in the major cities. There is a study which is carried out by Dr. Sagnik and his team. We are also part of this study. The urban component does reflect 0.52% increase in every 10 microgram rise in short-term beyond 2.5 exposure. This is all-cause mortality data collected from the municipality as far as the mortality is concerned, and satellite-based information was collected for PM 2.5. Our team has conducted similar study in the rural area, where we have a cohort of almost 100,000 population, which reported 0.3% rise in the incident rate ratio, the death related to the air pollution. Here again, it is important. We are studying the mortality. There is also lag effect of the air pollution, and the PM 2.5 has been reported in our study, almost 0.6% increase in the incident rate ratio. So there is a clear-cut evidence available both from the urban as well as the rural setting in India. Coming to the disease-specific evidence, the study by Prabhakaran et al. Reported that the higher average systolic BP, 1.77 millimeter of mercury, with respect to the higher exposure or monthly and the annual exposure. Both the diastolic as well as systolic blood pressure has found to be associated with the increased exposure to air pollution. The Histad et al., they carried out a study which reported 10 microgram per meter cube increase in PM 2.5 associated with the hazard ratio. So hazard ratio is the event to the time. So almost at given particular point of time, 1.05% major cardiovascular diseases. For example, myocardial infarction, stroke, what we called as a cardiac arrest in the local term, stroke, which is a sort of paralysis attack, and heart failure. They are found to be a positive linkages with all these cardiac events with the increase in the exposure of the PM 2.5. Ardina Koto et al. Also reported that air pollution exposure has a dose-response relationship. When we say dose response, so unit increase in the air pollution leads to the particular increase in the unit exposure, unit increase in the diastolic blood pressure as well as the systolic blood pressure. So the higher odds were observed amongst the women. Prachi Singh et al. Reported more hypertension among individual living in the area where the biomass fuel for cooking is more. So almost 1.15% more chances of developing the hypertension among the women who are using a biomass fuel. And if we sort of address it in terms of the population level attributes, so if you remove the household level biomass fuel, then that will prevent a loss of 70 to 91,000 daily every year. So, and it also has an economic impact in terms of billions USD saved. So that has this economic impact as well as the burden related to disease. For example, cardiovascular disease are well documented in India. Coming to the respiratory disease, Raj Parikh et al. Documented that ferric nitroxy oxide level higher in the group who are using a biomass fuel as compared to the LPG group. Also, they have reported the symptoms scores using a standardized questionnaire, and which was more there in the group which are using a biomass fuel. Coming to the maternal and the child health, Taux, Q et al., they estimate almost 3,49,000 pregnancy losses per year due to the ambient air exposure, which is more than 440 microgram per meter cube. That is accounting almost 7.1% in total annual pregnancy loss in South Asia. So India is one of the sites for this particular study. So you can also see here they have documented a dose response relationship in terms of 1.3% odds ratio, 1.3 odds ratio as compared with respect to 10 microgram per meter cube increment in the PM 2.5. Archana Patel in her studies from the central India reported increase in the perinatal mortality. Perinatal means in utero in the last few weeks of the utero as well as the postnatal early 28 days. So that is a perinatal mortality that reported to be higher in the households where the biomass fuel is being used from the central India. This study is documented. Again, coming to the respiratory disease, the Rajesh Kumar documented that the respiratory symptoms are more there in the industrial round when we compare with the non-industrial round. The obstructive ventricular defect, as well as when they adjusted for the various confounders, the impact was still significant statistically. So there is a clear-cut documentation from the ecological study that shows that exposure due to the industrial source air pollution has impact on the respiratory health. Jain Pandey et al. Did study in 2002 in India at AIIMS Delhi, which reported higher OPD visits with respect to the air pollution level, particularly in the emergency visit in asthma, COPD related to the exacerbation of the asthma. Gavande et al. In the study in the central part of India reported again the industrial people living in industrial zone have more episodes of respiratory issues. Similar findings were observed by the study by Krishnan M et al. Shabana Siddiqui also reported statistically strong evidence for PM 2.5 levels and the prevalence of lower respiratory infection. So there are also studies which not only reported the non-communicable disease related morbidity, but also the infectious disease related morbidity also. So the children and adolescents are reported to have more vulnerable for the air pollution by the studies carried out by the Sandeep Salve and Matthew et al., particularly living in the industrial and the commercial zone in Delhi. So the vulnerable population are also been sort of documented in the scientific literature from India. There are other studies which reported other diseases, for example, anemia prevalence, severe and the moderate anemia prevalence are reported more among the household who are using biomass fuel. I'm also sure there is one study carried out by the Sagnik and his team, which using NFHS data, which shows a clear increase in the anemia prevalence using satellite-based exposure assessment with the higher exposure of the PM 2.5. So if you see in nutshell, there is a lot of scientific evidence available from India, which documents the impact of major pollutants on various outcomes with respect to the diseases. Yes, the evidence is still being generated with the advance in the science in terms of measuring exposure with increase in the availability of the data with respect to the health data. There are more evidence which are being compiled. Globally also, there are newer diseases which are linked to the air pollution. I would like to highlight that, for example, mental health related issues, depression, anxiety disorder, the neurogenetic related developmental disorders among the children, and suicide rates. So these are a few newer health outcomes which are being linked to the air pollution related exposure. And India, there is a clear lack of evidence, particularly when it comes to the neurological diseases in India. So why there is a need to take action in air pollution related effects? Because it is responsible for 1 in every 8 death in India. It is the second most common cause of risk factor in India, and 99% population in India are exposed to the higher level of air pollution. So both the disease burden is on the higher side as well as the exposure is on the higher side. So on the both sides, there is a need to take action to mitigate the impact of air pollution on the health outcomes. Another important thing is our commitment with respect to the climate change and its impact on health. You can see here air pollution features here. So at the national level and the international level, we have made the commitments, international level political commitment to address all climate related issues. So also as a part of SDGs, the climate action feature here, air pollution, which is also part of it. Another, there are sustainable life and urban health related issues where the mitigation measures for reducing the air pollution exposures are inbuilt. So as a political commitment, you can say as a nation, we really need to work on this agenda of mitigating the impact of air pollution. So what should we do? What are the various actions we can do? What are the various domains under which we can do actions? I will describe this section on the basis of work we have done so far at AIIMS with the help of our collaborators. So domains of the action. So these are 5 domains I can largely put in under which the various actions can be taken. First is a collaboration with the various partners, scientific community and local community per se, generating a scientific evidence, advocacy and the communication, working with the national programs. It is very important, both sides, on the health sides and as well as from the exposure side. We have an NCAP and NPCCHH, that is National Program for Climate Change and Human Health, and National Clean Air Program. So it is very, very important to engage with the program so that you can take action through the system. And last but most important is the community engagement. You really need to interact with the community. So we will we'll discuss actions one by one. Coming to the collaboration. I believe this is the most important, as I said during my opening remarks, as this is the most lacking thing. So collaboration where you capitalize on the strength on various our respective streams. So when I talk about the IIT and the AIIMS collaboration, for IIT Delhi, we have a MOU where we have a sort of understanding between our joint collaborative work, through which we are working with a team of Dr. Saknik Dey's team at IIT Delhi, and I've also started working with Dr. Mukesh Sharma at IIT Kanpur. So what this collaboration gives? So this collaboration gives the multitude of strength. We have a strength of epidemiology, medical science, running core, network development, and IITs have strength of exposure measurement, technology, GIS, modeling. So we built on the strengths and we also overcome our limitations. Everyone is not expert in all the fields. So in order to overcome our limitation, it's very important to collaborate. And this is a very important message to all youngsters, young researchers who are joining. Never hesitate to collaborate with the stream which is totally different from your stream. By doing so, you are sort of leveraging on the strengths and limiting your limitations. And if it is possible, the institutional mechanism is key for sustainability. As I mentioned, the IIT Delhi and AIIMS has a joint MOU. So that helps us to continuity in terms of our efforts in research program and advocacy. I will give few evidences from our work which have generated a local evidence so far. So this is the study which we have carried out as a part of AIIMS IIT collaboration, where we studied both in urban and rural area. I have just mentioned the findings in the previous slides. The urban we covered the entire Delhi district, and the rural part was covered in the Faridabad, in the Ballabgarh block, where we have our field practice area or the cohort. So these are the variables which we have studied in this particular analysis, both from the exposure as well as the health side. In Ballabgarh site, we have the health data from last 40 years, which we have maintained in the computerized format in the health management information system. We also are among the very limited sites in India which can give you sort of a cost specific mortality, which we have used in this particular study. So these, just to inform other, I think all of you are aware, these are the sources of air pollution data with respect from, you can get it from CPCB, the Suffer app we are using. One of my students is working on Suffer app, its utilization. Just briefly about the sources of health data, morbidity. We have a National Family Health Survey. The fifth round of NFHS carried data is available. The longitudinal aging study, that is elastic study data. There are publications available from this also. GAT survey, which studies the tobacco survey. National Mental Health Survey. Currently, we are doing a National Mental Health Survey in the mega cities. Our institute is collaborating for the Delhi city. We have a national sample survey which collects the information on socio-economic parameters. National Crime Record Bureau, where the information on suicides, mental health issues can be brought in. And National NCD Monitoring Survey, which we carried out in 1617 with the help of ICMR and the Ministry of Health, where the non-communicable diseases related information is available. So these are the sources for health data which research and can use to generate a local evidence. Coming to the mortality data, we have all-cause mortality data available in the civil registration system, which we do routinely as a part of a death registration. We have a sample registration system, which is managed by the RGI. We have Minerva mortality in India established over autopsies at our department at AIIMS, where Professor Anand Krishnan is a principal investigator, and we all faculty members are part of the Minerva, where we have the information from cause-specific deaths for the almost 90,000 sample population across the India, what is the representative population, and all cause-specific mortality information rates are being published to this data, which is under control of Registrar General of India. Then there are other cause-specific mortality, as I said, MCCD, Medical Certification of Cause of Death India, and there are few national health programs which also use the cause-specific mortalities. So these are all various sources where the scientists can request for the data. Few information are available in the public domain. Few information is available on the request mode. So that can be used for generating science. So this is a publication which we got from the urban site, which I finding already reported. This is a data from the rural site where the daily mortality and the PM2.5 exposure has been reported. There's another work we did with Dr. Sagnika's team, where he provided us a satellite-based information, which helped us to generate evidence of, again, OPD consultation for cardiorespiratory illnesses and PM2.5 exposure in our hospital at the Pallabgarh, which is the secondary level hospital. This is one analysis. Again, this is an example to generate what we called as effectiveness study. What is the effectiveness of the various interventions which are there or implemented for reducing the air pollution related risk? So we all notice traffic ration system, odd and even, was implemented in Delhi in 2016. So we try to do analysis of hospital admissions in this. So we haven't found anything significant, but air quality related improvement was observed. This is again example of implementation based or accountability related studies, which we have done with the help of Drive project, which is again a collaboration with Dr. Sagnik and his team, where we assess effectiveness of various interventions. You can see here community-based intervention, traffic ration system, industrial intervention, and household level interventions, air purifier, electric heaters, improved cook stove, and behavioral interventions. So these analysis we have done as a part of systematic review, and these are currently in the phase of publishing. This is again one of the evidence to link air pollution and the newer health outcome. For example, the depression. This is a meta-analysis we did. This is not India specific. This is globally, because we have very sort of minuscule information from India, which shows the linkages of, you can see from the pooled estimate diamond here, linkages of depression and a particulate matter exposure. Now coming to, so there is a lot of scope of generating the local evidence still. We still need the data from various parts of the country, as mentioned by Dr. Neeraj, that this webinar is being attended from across the country participants. So it is very important to generate, and I sort of invite all young researchers to invest in the generating the local scientific evidences with respect to air pollution health impact. Now, coming to the next aspect, next domain of actions is working with the national program. As I said, the Ministry of Health in 2019 launched a national program for climate change and human health, and air pollution is an important part. We are at AIIMS are part of the Center of Excellence of Cardiopulmonary Diseases, where we have developed health adaptation plan for cardiopulmonary diseases. So this plan is there for obviously for the health officers at a district level to generate a health adaptation plan, which has actions to be done at various levels, including collaboration, integration, surveillance, monitoring, supervision, capacity building. So all this is the first time in India the action related to the climate and cardiorespiratory illnesses has been documented. This is the second work we did with IIT Kanpur with the team of Professor Mukesh Sharma, where the district nodal officer and their capacity building has been taken up. We have developed this first of its kind module for district health officers for air pollution and health effect related issues. We are with the Professor Sharma's team, we are working with the CPCB for reviewing the national ambient air quality standards. The report is in the final submission stage. You can see here as a capacity building of various health officials. Again, it is very important because these are the health officials who take the research findings or the actions at the ground level, at the district level, at the block level. So it is important to sensitize them, do the capacity building of the various levels. So this is again one of the initiative of K for India, which is a joint initiative between AIIMS and IIT Delhi, where Dr. Sagnik and myself are collaborating here. So we have the K for India website where you can locate the various studies which are published from India, from various states. So it is a sort of a one-go site to, if you really want to search for studies from India. So this is again important in terms of the evidence synthesis. Advocacy and the communication. This is again the most important domain where the action lies. So communication is important as far as health is there. So you can see as an advent of the new program in PCCH, we are working with the various tools of communication, be it app-based tools, be it poster, pamphlets at various levels, designing what is the best way to design, how should the message should be to the specific community. So this we are contributing. So we have this air health bulletin, which is published by the K for India. I invite all young researchers who are attending this webinar. If you think that we can cover your any work or any news related to air pollution and health effect in India, you are welcome to submit. You can write to caforindia @gmail.com, or you can write to my personal email at harshalsalve@ymail.com or aims.edu. So here the first bulletin we have published last year, and next bulletin is ready for publishing on this on the occasion of the International Day for Clean Air and Blue Skies. So again, this is a part of our advocacy and the communication to the larger audience, to larger community in terms of what are the recent evidences or recent science news available with respect to air pollution health effect research. Use of media is very, very critical because in both the print media, TV media, as well as the social media, it is important to use them to create advocacy, particularly with the community member, because unless and until we communicate the scientific findings of our studies to the media and to the community, it's of no use. So it is important to utilize the media for our advocacy as well as the communication of the finding. Advocacy at a various level, policy level, it is very crucial. It is essential to communicate right message to the right person, the specific message. What should health minister should do? What should health secretary 3 points for health secretary in terms of mitigating impact, 3 points for chairperson of the CPCB, what should they do in the NCAP, how integration can happen. Because a lot of time I get this question, you still see there is no integration of health in the NCAP. So what should they do to integrate the health sector in the NCAP? So that has to be made very specific to the policy. So this is again important advocacy skill we really need to do when we do the capacity building exercises for our scientists. The community engagement, where our action has to go, where we really need to see the behavior change. So it is important to engage with the community. As a part of drive, we engaged with the farmers in the rural Haryana to understand the issues related to the parali burning, what are the alternatives available, why they are, what are the issues, barriers and the facilitators for parali burning related issues. We interacted with the Panchayat Raj institutions. So we identified the facilitators and the barriers which are there for parali burning. So the solution also lies in the community. We really need to get solution from the community. Why it is important? Because then the acceptability of the solution is more when the solution comes from the community. So to have this social sort of aspect of addressing air pollution is more. Uptake of the intervention. One of our my student is doing has recently completed a thesis on the use of this SAFAR application, Samir application, use of mask, and the use of this PM Ujjwala scheme. So these are the very important evidences which needs to be generated at the local level in terms of what is the uptake of the intervention, what are the facilitator barriers of the intervention, so that the intervention can be modified accordingly. Coming to the last section, the challenges and the way forward. What are the challenges related to air pollution related research? So outcome assessment, as we said, it is very difficult to pinpoint the exposure and the outcome, because most of the non-communicable diseases which majority of burden of health lies are multifactorial in origin. It is difficult to pinpoint, and it is also very difficult to convince the policymakers. Exposure assessment is challenging. All of you are expert in doing exposure assessment. You can very well validate this finding that exposure assessment with respect to air pollution is really challenging. The science is still evolving. We are still working with the ecological based exposure using a satellite data or using a station based monitor data. The personalized monitor are very costly and they are also cumbersome use. Low cost sensor market is still growing. There is an issue with the calibration. So it's very challenging, but yes, the science is advancing and we really need to step up in terms of the exposure assessment is concerned. Important thing as far as the epidemiology is concerned, the exposure response relationship. So you can see here from this that the response is not straight. So if you really want to make a dent to the health impact, so you have to reduce the risk in a big way. So that's why you can see the majority of the studies, they are able to document the impact of interventions on the air quality, but majority of studies struggle to give evidence with respect to the health when it comes to the interventions, right? So why this is because we really need to find the intervention, and I will say the combination of interventions which has major impact on the exposure, so that you can see the impact on the health outcomes. So there is a sources and characterization of the particulate matter health risk is issue, chemistry related issues, in-depth understanding about the traffic related air pollution needs to be done, and vulnerability. As I said, there's still, in order to communicate the risk, the vulnerability assessment for the environmental exposures is very key, because if you see, you cannot tell the government and the policymakers that everyone is at risk. So what should they do? So it is important for advocacy and communication to tell that who is at a more risk, who are more vulnerable, what is the age group they are more risk, which gender is more vulnerable for air pollution related impact, which occupation is more vulnerable, what should you do? So this sort of evidence will help us to generate intervention which is specific, feasible, and robust, and likely to yield outcome. Funding collaboration opportunities. Again, this is a challenge, I will say. As I said, collaboration still remains a challenge. So we really need to step up on the collaborative research, collaborative work, and the funding with respect, because this is very resource intensive work when we do it to any environmental risk related studies. Particularly air pollution requires a lot of funding in terms of exposure assessment. So these are few challenges. So what are the way forward? So for young researchers who are joining the webinar, so knowledge and skill enhancement, again, for the self-epidemiology, exposure and outcome assessment is very crucial. So get yourself accustomed, get yourself equipped with the knowledge of epidemiology, exposure assessment, even though if you don't belong to that particular field, but it is important to get information so that you will able to generate a more scientific evidence or work towards this agenda. Take up a research idea for your thesis, dissertation, field-based work, anything if there is an opportunity. So take up idea of air pollution and health effect related research. Take up idea of related to the impact of the interventions, as I said, which are various interventions with respect to reducing the air pollution related exposure in your thesis. So as I said, all the medical colleges, we have almost more than 700 medical colleges. They have the urban field practice area and the rural field practice area mandatory by the National Medical Commission. And there are few SDSS sites. The Ballabgarh is one of the SDSS sites, that is health and demographic surveillance site. So these areas are being continuously monitored, or continuous surveillance happens there with respect to the health outcome. So this can be sort of utilized for generating the local scientific evidence. So there is need to collaborate with this institutes. Understand the priorities of local environmentalists or community needs. This is very, very crucial. If you really want some action, it is important to understand the local priorities which are there with respect to the air pollution and its health impact. That might be different. The priority in the southern part of country will be different. Priorities in the northeastern part will be different. So there is need to understand the priorities. Do not hesitate to take help. Identify the mentor under which you want to work. Identify the institute where you want to collaborate. So never hesitate to take help. This is my important message for our young researcher. Promote mentees. So for all, we have teachers here, the senior researchers, the PhD scholars are there. There is need to promote this mentee and mentor relationship through our various institutions, through our work, in order to have a sustainable and continued effort for addressing impact of air pollution and mitigating this thing. These are few, I just put a few of the important capacity building initiatives with respect to environmental health, which are available to various university institutes, through various ICMR related institutes. This is again particularly directed towards the exposure scientists who can take up a health related courses, short courses, so that to equip themselves or do capacity building. For professional association like IASTA, I have a strong request to make that to ensure due recognition to the environmental health in teaching and training curriculum. If you are working in this particular area, dedicated sessions at national and state level events. It is important because these sort of events ignites the brain of a young researchers, enthusiastic researchers to take up this idea. Dedicated leadership, capacity building course and the workshop through your professional association. Small grant, IASTA can have a small grant for young professionals. It not be larger one, small grants to ignite the minds of the young researchers and to kickstart work for larger proposal. Collaborating with the national program. As I said, we have our association IPHA, IAPSM, who are working closely with the program. So as an association, if you work with the program, for example, IASTA can work closely with the NCAP or a CPCB. So to sort of to have a knowledge sharing, to have a training and capacity building exercises embedded. Take a medical colleges institute along, as I said, the medical colleges or any technical institutes, IITs, engineering colleges, they provide a platform for sustainable efforts. They provide a platform for capacity building. They provide a platform for technical expertise. So it is very, very important to collaborate and to take your medical colleges and institute along. So these are a few requests for professional associations. Finally, so 3 Ps are there for successful leadership, and I believe all who are joining today can be a leader, and we need a leader and champion to take this agenda of mitigating impact of air pollution and health in India strongly. So we need a passion, perseverance, and partnership for advancing the science. And obviously, team effort is crucial for taking this agenda forward, because together we achieve more. So this is a brief about how you can join KEFR. So you can mail it to kefarindia@gmail.com, where we do capacity building exercises, join the research proposal, development related exercises. We have the KEFR webinar, where we do almost every 2 months, focusing on the various topics related to air pollution. We have this Twitter handle where we update with the various activity related to KEFR, and I already shared with you the air health bulletin, where we showcase the activities carried out through the KEFR. So I stop here. I'm happy to answer any queries if they are. Thank you so much.
Yeah, Dr. Sagdi, you can take care of this session now.
Yeah, thank you. Thank you, Dr. Harshal, for such a nice presentation. And the floor is open to questions. And already I see there is a question, so I will paraphrase it. So there is a question saying that, can we apply the research studies that you have presented today to other states of India? And would you find the results different or same across different states or cities?
As I said, I will say the purpose of research studies or publishing a research study, one of the most important purpose is a replication. So any time you look at the research studies, look at their methods and try to replicate that method, because that has been already validated methodology for studies. As I said, we have linked the satellite data of PM 2.5 and the mortality data. So again, this is an important method, to generate a local evidence. The same can be done at various states with the help of various medical institute. As I said, the various cohorts which are available, the existing cohorts which are available. So same thing can be replicated. So always look for a method which can be replicated for your study.
Dr. Neeraj, you have a question.
Thank you, Dr. Sagdi. Thank you, Dr. Harshal, for such a nice and informative talk. I have a question, couple of questions, if you don't mind.
Sure.
So first is, you said that you are writing many things, that every 10 microgram per meter cube increase is related to many other things. So first is, how do you define this increase of 10 microgram per meter cube? As a aerosol scientist, means whenever we are studying aerosol, there is a large variability in aerosol concentration. So sometimes it can be 20, sometimes it can be 40, 60. But when we are saying 10 microgram per meter cube increase, that means there has to be some time frame or some way you have to define that it is increased. So how do you define that?
Yeah, thank you for this question. Again, in most of the research studies, we use a statistical technique, what we called as a regression analysis. So in the regression analysis, what we do and what we sort of trying to provide is the unit increase in the dependent variable. So here, for most of the studies, dependent variable either is a daily mortality. I can give an example of our study. So daily increase in the mortality, and daily the independent variable will be the daily average PM 2.5 concentration. So once we get doing a regression analysis, we get this unit, what we call the regression coefficient, which gives you a unit of change in the daily mortality with the unit change in the exposure, that is PM 2.5. But so there is a unit change, that is a 1 microgram, but that change is very very small. So in order to have some sort of sense of the number, we multiply it by the 10. So that's why it's a 10 microgram per meter. So the daily average PM 2.5, 10, if it change 10 by 10, so this will increase by this much. So this is just for the easier understanding for the reader.
So let me take it a little further. So when we say PM 2.5, it is total all the particles more than 2.5 micron in size, but their composition can be highly variable. So sometimes it can be made up of full of metals and elemental carbon and those kind of things. Sometimes it can be purely sulfate, ammonium sulfate, and this kind of particles. So depending upon composition, so what I'm trying to ask that, see, this correlation is one thing, but once you go in mechanism, that how these aerosols are affecting.
Yeah.
So that their size and composition both will come into picture. So are you trying to address that part also?
Yeah. So as I said, in my challenges aspect, the chemistry and the composition of the PM 2.5 remains a challenge still in various research studies, because we do not have data what we require for association or the correlation related studies for this composition of the, let's say, example of the PM 2.5. I fully agree with you that the PM 2.5 have a different level of compositions. So I think at the small level, local level, I think Dr. Sagnik and his team trying to assess that. But again, we need a really robust science to have a larger data set with respect to the PM 2.5 composition particulate matter, and so that we can link that composition related, we can able to find the difference, that is very important.
Right.
Coming to the pathophysiology, the knowledge so far we got it with the size of the PM 2.5. Why PM 2.5 and now the ultrafine particles we are talking about is important, because it goes to the level of alveoli at the lung.
Yeah, that, yeah.
At the level of a microvascular related thing.
So that was another part. That means, so PM 2.5, sometime it can be dominated by very fine particles, like ultrafine particles, PM 0.1.
Yes.
And sometimes they
1.
all can be bigger particles. So that
Yes.
also will make difference, because how deep they can reach, that size will decide.
Absolutely, absolutely. So if you can see, as we are moving advanced with respect to the science, previously we are talking about the PM 10. Now in last 5 or 6 years or so, we are talking about PM 2.5, because we are able to measure the PM 2.5. So as we are able to measure PM 2.5, we are able to generate a more evidence due to PM 2.5. And now if you see, recently we have done a consultation as a part of KFAR India to provide a guidance for this National Ambient Air Quality Review process to CPCB, where we recommended that in the NCAP, PM 2.5 level should be considered for attainment and non-attainment city as a part of revision. Currently, it is PM 10. So, as I said, the science is evolving, and we really need to invest in the science. And as an association, I will say, this is a very important opportunity to advocate to the government, to the policy, to the funders, specifically to the state governments and the national government, to invest in the science so that the local robust evidence can be generated.
So how many samples you need actually to make a meaningful inference?
Again,
health and PM both. Means, suppose I'm giving you some composition for 1 year, but that can be weekly or something. But you have every day. So what is the number, at least minimum number of?
So it really need to be calculated in a scientific manner, the sample size. It depends. As I said, our study itself was what we did in the Ballabgarh. It was not powered to calculate, to give us a very robust relationship between cause-specific mortality and the PM 2.5 exposure. So if we go further down to the PM 2.5, we really need a huge data set. So be it NFHS, that's a huge data set, or the sample registration system, which is a huge data set. So we can use that health data. And if you really need to collaborate the exposure and the outcome in this data set, you need that level. For example, for the SRS, we have a cluster of 150 households in the country. So we need that information of the exposure, including the composition of PM 2.5 at that level. I think Sagnik and his team did the assessment of NFHS and anemia in NFHS and using a satellite data. So that they zero down to the pin code and zero down to the village code related level. So at the beginning, or what we call as ecological analysis. So this can be the first step. If we can able to generate using a satellite or any other method, pin code level, be it a very specific. Let's talk about the Delhi per se. If we can able to generate that data of the composition of PM 2.5, that can be the good beginning.
Last question. So you were talking about the environmental risk in the beginning, and then you showed that water has the effect obviously, then air has the effect. But you didn't mention anything about soil. But soil should also, because suppose we are growing vegetables and fruits in contaminated soil. So through roots, all those contaminants will reach to the vegetables and ultimately to us, which we will not know whether it is because of air or it is through your food, which is from different way. So what is your thought?
Yeah, sorry, I haven't mentioned that because I was focusing on the air pollution here. So I will give you one example. If there are someone who is a resident of UP, particularly in the Ganga belt, Bhojpur, Balia region. So I think you will be aware of arsenic contamination of the water there, right? Where due to high arsenic contamination, they have the skin pigmentation in the communities. And when we have visited them 5 years back as a part of some mandate given to us, so there is villages which were sort of empty. People flew their empty villages in due to this reason only. So it is important risk. The metals, the pesticide level through the soil, through the water, through the agriculture practices which are there. It is again a very, very important reason for environmental related health hazard. Another thing is climate variable. I haven't mentioned about a climatic variable, for example, rainfall, temperature, heat. Again, when we say the climate change, heat is an important determinant, and there's a lot of, recently we had a heat wave in Gujarat and mostly in the western and northern part of the country this year. So there is a lot of evidence available. We also carried out one systematic review which got published linking the heat related exposure and the mortality. So, and there is also in Ahmedabad, Gandhinagar, Ahmedabad, there is a model generated with the help of municipal corporation. Heat action plan has been generated to the various places. So there are various environmental risks, and we really need to, that's what in my various talks, I put this emphasis. In the health also, we talk very less about the environment, And nowadays, since when this climate change thing is coming up, we are talking about, because the recently last year, the World Health Day theme was planetary health, So this has to be taken up very vigorously in our talks, in our teaching, in the curriculum, environment health as an aspect, or environmental risk as an aspect of holistic health.
Sorry, that was my last question, but if you allow, this is the follow-up. So suppose the person is, just last question. So suppose the person is contaminated, means getting affected by all soil, water and air. So how we can delineate that, okay, what disease is actually because of soil or water or air?
So as I said, one of the challenges, most of the non-communicable diseases, which has a burden, has a multifactorial origin. So there are, I'm talking about a research setting. In the research setting, in the research studies, there are mechanisms or tools available. For example, various types of regression available. If you have the ample data of all the variables, then you can address or you can tell in a scientific manner using a regression technique what is contributing to how much. So, and also there are techniques which gives you a population attributable risk, the population attributable fraction, which means that if you remove that risk factor, how much impact will be there with respect to disease. So there are techniques available in the epidemiology that can use. But still, as there is a multifactorial causation, they also have the additive impact, as well as, so there are unknown confounders also that plays a role. But as a, I will say, the research tool, as a research studies, there are techniques available which gives you the magnitude and the quantum of impact of the various risk factors which you have a data on the various diseases.
Okay, thank you. Thank you so much for answering all my questions. And sorry, Sagnik, I asked too many questions.
No, that's why actually we have this, webinars, so that people can actually interact more.
Yeah.
Any other questions from the participants? I can't see any raised hands or. Okay, so there is a question.
Dr. Sapra, I think she wants to ask.
Yeah. Oh, please.
Yeah. I'm Dr. Sapra here from BRC. So unfortunately, I was not really able to see your entire presentation. I came in between. It is actually a general question to maybe even Sagnik Day or to Dr. Harshal or maybe even Neeraj. Now, when we are talking about this risk because of an excess of, say, for example, 10 microgram per meter cube above the levels, in a place like India, where our general PM 2.5 levels are quite high compared to the several countries other than India, I am not sure how one will start doing this unless we have our own, long-term studies, long-term health studies, and monitoring of the PM 2.5 long-term averages. Only then we will be able to comment something on the risk for the Indian population and scenarios. So I don't know how this can be addressed, but maybe one of you can try and answer this.
Yeah, it is very important.
I may say this is something like, in India we have high background patient areas of which all of us have heard. Now, whatever happens in the normal population when the doses are slightly high background doses, we cannot directly compare it with what is happening in a area which is already having a very high background. Because your body immunity, your adaptability, everything comes in. So, how does one address this issue?
Absolutely, where you are currently talking about adaptive capacity. In the terms of climate change, we call it as adaptive capacity. So take an example of Delhi. So where we have average PM 2.5, it is almost 3-4 times more than the rest of the country also. But we still don't see that event. Even if you see the AQI going to the 600 something, we don't see the people falling on the ground. We don't see people sort of rushing to the hospitals. So that is again important thing to study in terms of adaptive capacity, how immunity works, how sort of immune response work with respect to the exposure to air pollution that is there. And here you can assess this by doing a studies of sort of what we call it as a multi-site stratified level analysis, where you have low exposure setting, where you have high exposure setting. Then you can sort of compare what sort of immunological response, all health outcome related response you have. Coming to your first observation, respect to the 10 micrograms and others. So this is a statistical number, So this is applicable universally. So that is a statistical number which is generated using a regression analysis that can be replicable across the board. Sagnik, you want to add anything?
Yeah, so I want to add, actually, I think this is very important point. Two things. One is that when we talk about health impact, we should be very clear what are we talking about, the acute exposure or chronic exposure. In terms of acute exposure, what has been observed is that if the baseline itself is very high, like Delhi or any other place in the Gangetic Plain, versus relatively low baseline PM values, then the same magnitude increase is actually going to give you different results. If you compare all the studies that are out there from India, in fact, I will tell you the short-term impact of 10 microgram per meter cube increase in PM leads to much lower impact in terms of any health outcome, in terms of short term. So in a sense that people are more sensitive when actually they are living in a much cleaner condition. However, when we talk about chronic exposure or long-term exposure, then the situation is very different. And they are also based on the latest epidemiological studies, cohort studies and all. Some of them are actually from India. This suggests that your risk starts to level off when you are at very, very high exposure. So it means that people are not very sensitive. So when you are already 400, 500 microgram per cubic meter condition, then same magnitude change is going to, lead to much lower, change in the health outcome rather than when you are at the steeper end of the curve. So there are, efforts actually, and I think I absolutely agree. And I will just reiterate what Neeraj was asking, that this is where we means as a community, we should move, that bring the composition, as Dr. Harshal also mentioned, we do not have enough epidemiological evidence as of now to guide policy when it comes to composition. But everyone understand that composition is very, very important. Whatever little study is there, it is very clear, like dust is much less impactful than black carbon or any other, combustion generated particles. So I think as a community, we should move there. Any other questions from anyone?
I think she has a follow-up question, something what she was asking.
Okay, yeah, go ahead.
Have you raised the hand, Dr. Safra? No?
No, no, no. I was only thanking you for
Okay,
the
okay.
reply.
Okay, okay. She
Thank
was
you.
saying thank you.
Yeah.
Okay, okay. Okay, so any question? In that case, Harshal, I think, I have a question, and if you comment on how actually the health community should guide, because I'm asking this, I know that you are involved, because India is undergoing currently the national standard revision, which is a very, very important point. And how do you see the whole thing is panning out? Like, what should be the revised standard? Because then measurements, aerosol science, everything will, follow actually whatever the new standards that are going to be announced for not just PM, but for many other pollutants.
So thank you, Sagnik. So as mentioned by Sagnik, that I'm doing the health part in this all NQAS revision, which is given the mandate given by CPCB to IIT Kanpur team led by Professor Sharma. So as a part of mandate, what we're doing is first, we are compiling the evidence of the health, what is there, and those responsibility relationships, what I have shown mostly. Then in terms of the exposure thing, the team from the exposure science from IIT Kanpur, and there's an NPL also, they're part of this team. They're working on the strategic measurement of the air pollutants. Sort of, and I also believe that something which you should take action upon. There is no point in, because the research is a separate part. Research, you should keep on more detail, as mentioned by Dr. Neeraj, that composition matters, chemistry matters, everything matters in the research. But when it comes to the program, the CPCB is a program and the regulatory authority. So when it comes to program, you really need to be clear that for what I should take action, what I can measure accurately, what I can measure with the whatever resources I have. So that much should be there in the standards, and it should be strategic. In the health surveillance and health epidemiology, we talk about the strategic surveillance. We should not do everything everywhere. We need to identify the vulnerable population. We need to identify the vulnerable area where we should measure some air pollutants more frequently, include more pollutants. And in general, where there is a sort of non-vulnerable, I will say, the less vulnerable population or a geographical area, we should restrict to the commonly measured pollutants, which are there, evidence available, for which you can take the action. Right? For example, if we can, I'm just giving a hypothetical example. If you have the benzene, so what action you can take in a programmatic manner? It's very limited action you can take. There's a limited evidence which is available. It is a part of the standards. So we really need to think on these lines, more action oriented, because if you review the standards, let's say, just fix it. What after 5 years I will review? What is the outcome I have achieved? So this is very important, action oriented, and the strategic, I will say, the monitoring, which is key for this revision, I guess. But it's again a long process. It will take another year or so, hopefully, to achieve its own goal.
Yeah, I think that really valuable. There is a comment actually in the chat box, and I completely echo that comment that so far, most of the evidence are for PM10, PM2.5, but actually there are also many other criteria pollutant like NOx, ozone, and all, for which very less evidence is available, at least for India. So there I am very sure IASTA can play a major role in providing the exposure data sets. And I personally also believe that IASTA and CAFR India can really work together further to advance the science in this particular field. So with that, are there any final thoughts, questions by anyone?
So just to continue what Sagnik said, I request Dr. Neeraj, because he's leading this IASTA, we will have more collaborative work with the K for India. We do a capacity building exercises. So definitely we'll invite you to sort of inform our participants regarding whatever opportunities are there in terms of the data sets, in terms of capacity building exercises at your end. So this will help us to sort of collaborate further, and the exchange of ideas can also happen. So that definitely will take you on the board. Yeah, thank you.
Looking forward.
Okay, thank you. So I think let us end today with vote of thanks. So Dr. Harshal, who is a colleague, friend, thank you again, sparing time for this valuable talk. I'm very sure, IASTA people, members have been, quite excited. This is one area where definitely we can make a lot of inroads. I want to thank Dr. Neeraj, Dr. Joshi, Dr. Sapra, Dr. Panditrai. I see Dr. Verma, many IASTA members who have joined, and also the participants. They are joining these monthly lectures, and this is really a good initiative by IASTA to further spread the aerosol science and opening doors for future collaborations. So with this, thanking everyone from my own behalf and from behalf of IASTA. We thank everyone for the participation. Yeah, good evening and bye.
Yeah, thank you. Thank you all.
Thank you.
Namaskar. Bye.
The recording has stopped.